Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY 5 resident at the University of Pittsburgh, and today we will be continuing with part 2 of our lecture on head and neck anatomy, this time focusing on the anatomy of lymph node regions. In part 1 of head and neck cancer anatomy, we focused on identifying the different disease sites within the head and neck and the various subsites within each of those areas, and different substructures and important anatomical landmarks. In this talk, we're going to talk about some important principles of lymph node anatomy, including how we define the different lymph node levels within the head and neck. And we'll also talk about principles of drainage. So we'll talk about how different disease sites tend to drain to different lymph node levels, again, depending on their anatomy. There's a nice paper that was published in the Green Journal in 2014. The first author is Gregoire. I have it referenced here. And it's called Delineation of the Neck Node Levels for Head and Neck Tumors. And I think it does a really good job of showing you how to contour each and every level and the different anatomical landmarks that help you to define that level. So I would definitely refer you to that paper if you're working on head and neck contours. The image on the right-hand side of this slide kind of shows an overview of the different lymph node levels and their different numbers. So we refer to the lymph node levels by a number. So there's level 1, 2, 3, 4, and so on. In this talk, we're going to talk about the 7 different lymph node levels of the head and neck. And keep in mind that within each disease subsite, the numbering of the lymph node levels can be a little bit different. So here we're going to focus on the numbering in the head and neck. If you get into kind of the mediastinum and the mediastinal lymph node levels, those will have a separate kind of numerical order. So here we're really going to just focus on the head and neck lymph nodes. This slide is probably quite daunting, but it goes through the 7 different levels that we're going to talk about. So level 1 are our submental and submandibular lymph nodes. Level 2 are our upper internal jugular, 3 is middle internal jugular, 4 is lower internal jugular. 5 is kind of the posterior triangle, so the nodes that sit posterior to levels 2 through 4. 6 is the central compartment, and then 7 we refer to as our retropharyngeal nodes. This table is something that I made based on that paper from the Green Journal, and it kind of delineates all of the different borders, the superior, inferior, anterior, posterior, lateral, and medial borders of each of these different levels. And many of these levels can also be just divided into A and B. So for example, 2A versus 2B, 5A versus 5B, and so on. This is here for reference, and again, for more complete reference, I would always ask you to look at that paper that we talked about, but I'm going to try to go through the anatomy kind of a little bit more practically and show you images and things like that to hopefully make a little bit of sense. I'm going to start by talking about lymph node levels 2 through 4, because I would say these are by far the most commonly involved nodal levels when patients present with head and neck cancer. And when we're doing elective nodal coverage, we're typically always including levels 2 through 4 with some exceptions. So levels 2 through 4 are the internal jugular nodes, and levels 2, 3, and 4 are the upper, middle, and internal jugular nodes. So all of these nodes sit on the inside of your sternocleidomastoid muscle, and they basically follow your carotid artery, either the common carotid or the internal carotid, depending on which level we're at. So they follow the carotid artery and the internal jugular vein all the way down from the base of skull as they travel towards the heart. So the levels 2, 3, and 4 all have the same lateral and medial borders, and they basically sit right on the inside of the sternocleidomastoid muscle. And so their entire lateral border is the medial border of the sternocleidomastoid muscle, from the anterior aspect of that muscle all the way to the posterior aspect. And they include the blood vessels as well as the fatty space around those blood vessels. And the medial border is the carotid artery. And then when we're drawing these nodal levels, we really just make sure that we're including the blood vessels, the fatty space around the blood vessels, and we're not including any muscle or tissue or anything like that. And then levels 2, 3, and 4 are just, running down the neck all along the inside of the sternocleidomastoid, and they are separated by various landmarks. So 2 sits on top of 3, which sits on top of 4. And as a result, they all have different superior and inferior borders. So imagine, you're contouring these muscles. They're on the inside of the sternocleidomastoid muscle. The medial border is the medial side of the carotid artery. And level 2 starts superiorly at the base of the skull at the jugular fossa, and it goes from the base of the skull all the way down to the inferior aspect of the hyoid bone. So level 2 goes from base of skull to the bottom of the hyoid bone. Level 3 starts right where level 2 left off, and it goes from the bottom of the hyoid bone to the bottom of the cricoid cartilage. And then level 4 goes from the bottom of the cricoid cartilage, and inferiorly it goes down to the level of the clavicle. Oftentimes, unless level 4 is involved and we're worried about lower level 4 involvement, when we're just covering level 4 electively, we're going to stop contouring about 2 centimeters above the sternal notch. So just remember, levels 2, 3, and 4 are the internal jugular nodes. They all sit medial to the sternocleidomastoid muscle, and level 2 goes from the base of the skull to the bottom of the hyoid. Level 3 goes from the bottom of the hyoid to the bottom of the cricoid, and then level 4 is from the bottom of the cricoid down to the clavicle and sternum, but in reality, we often stop contouring about 2 centimeters above the sternal notch. And because the hyoid and the cricoid cartilage are such important landmarks to differentiate levels 2 from levels 3 and levels 3 from level 4, we spent a little bit of time in part 1 of the anatomy lecture actually going through what those anatomical landmarks look like on a CT scan. So if you need to review that, I would refer you to part 1. And towards the end, we actually show some slices of a CT scan and point out what the hyoid bone looks like and what the cricoid bone looks like, the cricoid cartilage looks like on a CT scan, because that is how you can identify these different lymph node levels. Here are some images that I actually took from econtour.org, and these I think are good examples of contouring levels 2, 3, and 4. So these are obviously all contoured on the right side, so these are right level 2, right level 3, right level 4. And the only difference between these different levels is basically where in the head and neck they are, kind of along the craniocaudal plane. So let's take a close look at level 2, the level 2 contour here in this image. So in the level 2 contour, you can see that the green line, which is the contour, sits just medial to the sternocleidomastoid muscle, and it basically travels along the length of that sternocleidomastoid muscle, and that is the lateral boundary. There are some more medially located muscles, and we are kind of using those muscles as our medial boundary, and we're just kind of drawing a line around the more hypodense, so that darker space, which represents the fatty tissue, and that is where lymph nodes could potentially be. So we're drawing a line along the inside of the sternocleidomastoid muscle, and then we're continuing that line along the inside of the outer boundary of some of those muscles in the head and neck. And we are continuing that line to include the carotid artery and the jugular vein. And the medial aspect of the carotid artery is kind of the medial aspect of our contour. And then we're kind of stopping we're stopping anteriorly in front of those arteries. And anterior to this level would actually be level 1B, which we'll talk about, which is the submandibular level that includes the submandibular gland. So we're kind of going along the inside of the sternocleidomastoid muscle. We're wrapping around the blood vessels. We're making sure to include all of that dark fatty space. And then we're kind of stopping posterior to the submandibular gland because that is a different level. That's level 1B, which is the submandibular nodes. As we move inferiorly, once we get below the hyoid bone, we are in level 3. And so the anatomy changes because our upper part of the neck looks very different than the lower part of the neck as we get closer and closer to our clavicle. But in level 3, we know that we're in level 3 now because we can see the thyroid cartilage and the arytenoid cartilage there. So the thyroid cartilage is that V-shaped cartilage that's sitting anteriorly to the larynx. And we're still kind of using the same exact principles. So we're drawing a line along the inside of the sternocleidomastoid muscle. We're making sure that we include all of the fatty space that's on the inside, but we're not including any of the muscles that sit more medially. We're making sure that we wrap our contour along the blood vessels, and roughly the anterior and posterior borders of the sternocleidomastoid are the anterior and posterior borders of our nodal volume. And then level 4 is, the same thing, but this time we know that we're inferior to the cricoid cartilage. And again, we're kind of tracing the inside of the sternocleidomastoid muscle and including all of that fatty space. But now that fatty space opens up a little bit, and so that contour looks a little bit thicker. So these are just representative examples of level 2, 3, and 4. Again, for detailed guidelines, I would refer you to that contouring atlas on how to delineate these levels. And as you get more practice with contouring lymph node levels, and as you get real-time feedback from attendings, it's definitely a skill that we all get better at. We're now going to jump to the retropharyngeal nodes, which are the level 7 nodes. They're also called the Rouvier nodes. So retropharyngeal nodes are located posterior to the pharyngeal wall and kind of anterior to the prevertebral fascia. And I kind of think of them as a cranial extension of the level 2 lymph nodes. So these retropharyngeal nodes, we really want to cover for any tumors that are involving any part of the pharynx. So if there's pharynx in the name, so if it's nasopharynx, oropharynx, or hypopharynx, you definitely want to cover the retropharyngeal nodes. So you can kind of think of it as part of the level 2 to 4 chain, and the retropharyngeal nodes are really just posterior to the pharyngeal wall, and they go all the way up to the base of the skull. And an example of contours, again from eContour, is shown here in this slide. The level 5 nodes are located in the posterior triangle, and they're located sort of posterolaterally to levels 2 through 4. So as we're contouring levels 2 through 4, remember we talked about stopping at the back of the sternocleidomastoid muscle. So that, the posterior edge of the sternocleidomastoid kind of corresponds to the posterior edge of our levels 2, 3, and 4. If we were to extend our contour and include that fatty space that is posterior to the sternocleidomastoid muscle, that is the posterior triangle, and that's where level 5 nodes are. So level 5, levels 2 through 4 are often covered by default in our elective nodal volume. Level 5, we typically cover electively if we're dealing with a nasopharyngeal tumor. And if we have involvement of a level 2 through 4 node, then we also cover level 5, just because now that we know that there's a level 2 through 4 node involved, whichever side that node is involved on will cover that ipsilateral level 5, since it's an adjacent level. So that's kind of the principles of, one of the principles of coverage. If nasopharynx is involved, then those are at risk of spreading to level 5, so we definitely want to cover level 5. And then if there is a level 2 through 4 node involved, because level 5 is adjacent, whichever side we see that involved node, whether it's the right or the left, we would just cover the ipsilateral level 5 as well. That brings us to levels 1A and 1B, which are the submental and the submandibular nodes. So we already kind of mentioned the submandibular nodes, which are levels 1B, and these include the submandibular gland, and they sit kind of right in front of level 2. And they basically include the submandibular gland, and they sit kind of posterolateral to the anterior belly of the digastric muscle. Level 1A is the submental nodes, and these are anteromedial to the anterior bellies of the digastric muscle, and they are located kind of centrally and inferior to the oral tongue. So submental and submandibular, the location is really in the name. So the submandibular are kind of the nodes that sit around and include your submandibular salivary gland, and then the submental nodes are the nodes that are just underneath your chin, so just inferior to your oral tongue. If you put your hand on your chin and kind of go back and go to that soft tissue that's right behind your chin, those are where your submental nodes would be. So just like we said with level 5 coverage, like if there is an ipsilateral level 2 node that's involved, we would cover that ipsilateral level 5. Level 1B will often be covered if there is a level 2 node as well, especially if it's a larger level 2 node. We think about covering the ipsilateral level 1B Again, just because it's an adjacent nodal level, and once level 2 is involved, then we worry about spread to the ipsilateral level 1B as well as level 5, and so we cover those, especially for tumors that are on the larger side, like greater than 2 centimeters. Level 1B, the submandibular nodes, are also covered for many oral cavity cancers, and most of the time when we're dealing with an oral cavity cancer, we will cover bilateral level 1B electively. Level 1A is typically reserved in select cases for oral cavity, especially tumors that are located more anteriorly, like the tip of the tongue, the anterior part of the floor of the mouth. That is when we think about covering level 1A or the submental nodes. The other point I'll make here is that all of the lymph node levels that we talk about, including the retropharyngeal nodes and level 1B all the way down to level 5, these are typically covered bilaterally, so you have to contour them separately on the right side versus on the left side. The submental nodes, level 1A, are really kind of, it's hard to differentiate bilateral because it's just one compartment since they're so centrally located. So the level 1A, there's really just one central compartment, and that kind of applies to level 6 as well, which are centrally located nodes. So if they're laterally located, then we have kind of bilateral levels that we can talk about. So you can talk about a right level 2 versus a left level 2, or a right 1B versus a left 1B. But level 1A are so central in that submental region that there's really only one level 1A. That also applies to level 6, as we will see, which are the central neck nodes. So here are images from eContour once again showing examples of level 1B and level 1A. So 1B are the submandibular nodes, and you can see in the more superior picture they include the submandibular gland, and then inferiorly it's just an extension of that fatty space, and then more medially in the central compartment we have level 1A, which are the submental nodes. And you can see here they're so centrally located, you wouldn't be able to draw right versus a left level 1A, you're just drawing a single central level 1A. And level 6 kind of falls into that central neck compartment as well. So level 6 includes many different areas, so in pretracheal nodes, paratracheal, prelaryngeal, which are also known as your Delphian nodes, and then your perithyroid nodes. And they can technically be divided into 6A and 6B, and the exact boundaries are shown here. Level 6, I really just think of as the central nodes that are located anteriorly to the larynx. And if you recall from our last lecture, we mentioned that tumors that are located in the subglottis, so subglottic laryngeal tumors, or any tumors of the larynx that have subglottic extension, these areas are really at risk of draining to level 6 nodes. And so we definitely need to cover level 6, especially if we have a subglottic tumor with subglottic extension. I think at this point we have covered levels 1 through 7. So we talked about levels 1, which are the submental submandibular. We talked about 2, 3, and 4, which are the internal jugular. We talked about level 5, which is the posterior triangle. We talked about 6, which are our kind of central compartment neck nodes, including our Delphian nodes. And then we talked about 7, which are the retropharyngeal nodes. There are a few additional levels in the head and neck, so there's 8, 9, and 10, and these include the parotid, preauricular, facial, retroauricular, and occipital nodes. I'm not going to get into too many details here because I think this alone is a lot to digest. So for full details, I would refer you again to that paper from the Green Journal that we referenced earlier. Hopefully now we have a better sense of the different levels that exist in terms of head and neck lymph nodes and how to go about contouring them if we had to. I'd like to wrap up the talk by talking about some principles of lymph node drainage and how we actually think about which levels of lymph nodes to cover depending on the disease site. There's another paper, again in the Green Journal, this time published in 2019, and the first author is Dr. Biao. This is called selection of lymph node target volumes for definitive head and neck radiation therapy. And this paper really nicely kind of systematically goes through the different disease sites, and it has a table for each disease site, and it nicely kind of outlines which elective lymph node levels we should think about covering based on the disease site that we're treating. So based on this paper, I'm going to try to go through some very general principles. But again, this overview is extremely general, and I would refer you to that paper for more complete details. The reason we care about general principles of lymph node drainage is because if there's a particular lymph node region that is at high risk of involvement, and we know that a particular subsite drains to that level, we want to cover that as part of our elective nodal volume. And to kind of better understand what that means, I want to just go through some general principles of head and neck radiation. So typically when we're treating with radiation to the head and neck, we're either treating with definitive radiation or we're treating with postoperative radiation. So definitive radiation means that that is their one and only kind of local control treatment. And in postoperative, that typically means that they had surgery, but they had certain high-risk factors. And so we're trying to give some additional radiation on the back end to reduce their chance of local recurrence. In both the definitive setting and in the postoperative setting, if the risk is high enough, then we will often add chemotherapy, but we don't always need to add chemotherapy. And then typically, in both settings, we have what we call a high, intermediate, and low risk volume. And what is included within the high risk, intermediate risk, and low risk volume, as well as some possible doses that we would take that to, these are all included in the table here. So let's look at definitive radiation and pretend we're treating, say, an oropharyngeal cancer with definitive radiotherapy. And let's sort of talk about the high, intermediate, and low dose levels and what they would be. So let's say that a patient has a base of tongue primary and they have a level 2 lymph node that's involved. The high risk volume would include the tumor as well as any involved nodes. So if they have a base of tongue primary that's on the right side, we would contour that tumor. And if they have a right level 2 lymph node, we would contour that lymph node as well. And then we typically add a small margin to the primary tumor and take that to our highest dose level. And in the definitive setting, that is often something like 70 gray and 35 fractions. Then we have an intermediate dose level, and oftentimes in the modern era, these intermediate and low dose levels are treated as a simultaneous integrated boost. So we do 2 gray per fraction to our high risk volume, 1.8 gray per fraction to the intermediate risk volume, and 1.6 gray per fraction to the low risk volume. So the intermediate risk volume typically includes either the entire subsite or a larger margin on the primary tumor itself, and then also the entire involved nodal level. So in this example, say we have a level 2 lymph node that's involved on the right-hand side, then the entire right level 2 level would be taken to that intermediate dose. So now we're including, the node itself is taken to the high dose, but then the entire level of that involved node is taken to the intermediate dose. And then finally, we have our elective nodal volume. So for oropharyngeal cancers, we know that these cancers are at high risk of spread to the bilateral neck because the base of tongue has a rich lymphovascular drainage to bilateral sides of the neck. And so it's not enough to just cover the side that's involved, we have to cover the contralateral side as well. And the nodal regions that are typically involved for oropharyngeal cancers are the retropharyngeal nodes and then levels 2 through 4. So bilateral levels 2 through 4, as well as bilateral retropharyngeal nodes are going to be included in our elective nodal volume. Keep in mind that the right level 2 we were already taking to the intermediate dose, so by default that's going to get a low dose, but it's actually going to get a higher dose. So then what we have left is bilateral retropharyngeal, right levels 3 and 4, and then left levels 2 through 4 as part of our elective nodal volume. Also, if that node is large enough on the right side, we might consider electively including levels 1B and 5 on the right-hand side, because remember, those are the adjacent levels that sit just anterior and posterior to level 2. So we would probably consider including level 1B and 5 as well in our low dose volume because those are kind of adjacent. So that's just an example of high, intermediate, and low risk volumes for an example case in the setting of definitive radiation for an oropharyngeal cancer that originated in the base of tongue. These same principles we think about across all sites of the head and neck, and even in the postoperative setting, we typically will cover the tumor bed with our high risk volume, the operative bed with our intermediate risk volume, and then there's an additional elective volume that we might consider taking to a low dose of radiation. So in the definitive setting, our maximum dose is typically 70 gray. In the postoperative setting, our maximum dose is 60 to 66 gray. We take it to 66 gray if there's something like a positive margin or extranodal extension, but assuming that's not the case, our high dose is 60 gray. And then the intermediate dose is 57, and the low dose, which is something around 54, we can often treat an additional elective volume to that dose. So just to give you an example, let's say somebody has an oral cavity tumor and they had an ipsilateral neck dissection. So they had a right-sided anterior tongue tumor, so oral cavity this time, and they had an ipsilateral neck dissection. We would definitely treat all of the operative bed with radiation, but we would also, in this case, assuming that there was a high enough depth of invasion, we would treat the contralateral neck as well. And so we would probably include something like the left levels 1B and then 2 through 4, because, in oral cavity, we do worry about involvement in the contralateral neck as well. So these are just rough examples of high, intermediate, and low risk volumes and what they might look like in the definitive versus in the post-operative setting. Remember, most disease sites we're going to cover at-risk lymph nodes bilaterally with our radiation, and there are certain tumors, so well-lateralized tonsillar tumors that don't involve the base of tongue or soft palate, as well as certain oral cavity tumors that we might consider treating to the unilateral neck alone. So again, that paper that I referenced earlier has really nice guidelines on which exact nodal levels to think about covering for particular disease sites, and also based on consideration of where the primary tumor is spreading. So on this slide, I've tried to summarize some very general principles of lymph node coverage. And again, this is probably not a completely accurate list 100% of the time, but hopefully it gives you a general overview so that you can approach this. And then obviously, when we're contouring each case, we approach on an individual basis and make unique considerations to that case. So general principles of lymph node coverage. Levels 2 through 4 are going to be covered almost always. Almost always, we're going to be covering lymph nodes bilaterally, except in the case of well-lateralized tumors that are localized to the tonsil with no base of tongue or soft palate involvement, and also in certain well-lateralized oral cavity tumors. Anytime you have disease involving any part of the pharynx, so nasopharynx, oropharynx, or hypopharynx, you always want to cover your retropharyngeal nodes. For nasopharyngeal tumors, you additionally want to cover level 5 as well as the retropharyngeal and levels 2 through 4. For subglottic tumors, you want to cover levels 2 through 4, and you'll also want to cover level 6. For oral cavity tumors, we're typically always going to be covering levels 1B and then 2 through 5, but there are certain oral cavity tumors where we also think about adding level 1A, which are the submental nodes. So those are areas like the lower lip, the anterior oral tongue, and the anterior floor of mouth. We think about covering level 1A. For tumors of the upper lip, they can actually drain to our facial lymphatics, and so we need to cover the facial lymphatics. And then the last principle is that generally, if a given nodal level is involved, we consider covering the adjacent nodal regions to a low dose volume. So for example, if right level 2 is involved, we're going to cover that with our intermediate dose volume, and then we might consider covering adjacent levels 1B and level 5 with low dose, just because they're adjacent to the involved nodal level. This table is probably super oversimplified, and it, again, may not always be accurate, but I tried to take some of the very general rules as to when to cover which particular levels depending on the disease site. So the boxes that are in green are levels that you always think about electively covering. The orange are kind of based on the anatomy. So oral cavity, remember we said if it's lower lip, anterior tongue, like the front part of the anterior tongue or the anterior part of the floor of the mouth, that is when we would think about covering the submental level 1A. And then levels 1B through 5, it's typically if an adjacent nodal level is involved. So if anything in 2 through 4 is involved, then we typically think about adding, say, 1B or level 1-5, again, depending on where the involved nodes are. So again, these are highly, highly generalized recommendations and may not always apply and be completely accurate. For complete reference, again, I have that Green Journal article referenced on this slide, but hopefully this just gives you a good sense of which levels we typically think about covering based on the disease anatomy. That brings us to an end of part 2 of head and neck cancer anatomy. Head and neck cancer anatomy is extremely complicated, and we haven't even gotten into some of the super nitty-gritty anatomical features, including the different base of skull foramina and the different pathways of the cranial nerves. That I think we'll definitely save for another time. I think before you learn the details of how we manage head and neck cancers, the most important things to understand is how we divide the head and neck into different anatomical subsites, and also understanding how we divide the head and neck into different lymph node levels and when those lymph node levels in particular are at risk of being involved. So again, the stuff that I talked about in this particular lecture and the recommendations for elective nodal coverage, they may not 100% apply to every single case that you encounter, but hopefully this gives you a general overview of some basic principles that we can apply kind of broadly to our head and neck cancer patients. That wraps up everything I wanted to talk about in terms of a general overview of head and neck cancer anatomy. Hopefully this was helpful to you, and I look forward to future talks where we will dive into the evidence base for management of head and neck cancers. Thank you so much for your time and attention.